Thank you, everybody. This is a study, actually, we did it during the COVID era in the throughout the 2021 for last 1 year. What prompted me to do this study? Begin it that total case in the world till today is 57 crores. That is not important. Important is the number of cases recovered is near about 54 crores. We have now in the world 50 crore population recovered patient. And that in the India, it's near about 4.5 crore. But we do not know still what is the impact of the sequelae of the COVID-19 so far the cardiovascular disease is concerned. Researchers found abnormalities almost as high as 30 to 80% patient involving the cardiovascular region after COVID-19, either acutely or subacutely, even after 3 months, up to 1 year. That we know. We do not know beyond 1 year what will happen, beyond 2 years what will happen. That we have to study again. We know COVID-19 is basically involving the respiratory illnesses. But in many patients, the myocardial injury occurring during the acute phase of COVID-19 may lead to long-term sequelae such as myocardial fibrosis and or persistent myocardial inflammation. Besides this, in some patients, COVID-19 may also result in development of new onset cardiomyopathy, particularly during the convalescence phase after the initial infection. Where is my actual area of interest? The nature of injury and how that happens, we now know fairly well. So far, the literature is concerned. But it is important that autopsy series of patients of sudden cardiac death have identified myocarditis as a potential explanation in a significant number of cases, even with a grossly normal appearing heart. That is most important. And the finding of myocarditis as a significant cause of sudden death in the young adult is a notable and relevant to survivors of COVID-19. We do not know still now optimal screening for patient after recovery after COVID-19. But there is certain algorithm, certain things people tried to find out. Look at the right side of this, and if I zoom it, you will find during the convalescence phases of 2 to 6 months, these are the very robust calculator. First you do the ECG, and one baseline echo. You monitor the cardiac status clinically or with the ECG and the echo, and consider patient-specific cardiac risk factor. If you find anything abnormal, you must do further studies. Particularly the two are being advocated. One is the echo with strain, and second is the LG MRI scan. But considering the burdens of 4.5 crore recovered patient, if I want to do the LG with MRI scan, probably will not filling up in the, that much of MRI we don't have in India. But what we can do is the LG, is the echo with strain. That can be done. And that is the thing, it prompted me to do the study. Because what we know is the coronavirus disease can cause overt and the subclinical myocardial dysfunction. And we know all that to determine the subclinical myocardial infarction, the echocardiographically, GLS is the most important, the robust and reproducible parameters till known. So, the residual cardiac involvement during the convalescence phase is very, very important. Why? Because if we can detect them, then trial of prophylactic therapies to prevent the long-term complication may be appropriate. We may prevent sudden cardiac death We may prevent sudden arrhythmias. We may prevent unexplained myocarditis. It is recommended that we do the standard ECG and the echocardiogram, but unfortunately, many of the patients fail to show any abnormalities. Unfortunately, there is a very little study available even in the world literature, and two from India. Only a few studies have reported GLS in patients with the recently recovered with the COVID-19. A study from North India included only 134 patient subject within 30 to 45 days after recovery from COVID-19. Only those with normal LVF were included in the study. Subclinical LVD systolic dysfunction defined as GLS less than mean value in control was seen in only 30% of patients. Another study included only 100 patients recovered from COVID-19 at a median delay of 130 days. Overall GLS was not reduced in the post-COVID patient, but the basal segmental longitudinal strain was found to be lower. And another study of COVID, 86 studies, that is a world study, survival rate, median time interval 327 days after recovery, compared with the control, no significant difference was found in any of the echocardiographic parameter, including DLS. But these are very small study. And what prompted me to this study, we recruited patient at a median interval of 12 weeks after the initial infection. Much like the previous studies, we also found that GLS was significantly reduced in post-COVID patient as compared to the control. Majority of our patients had LVF within normal, almost all in fact, range, yet had significantly reduced GLS, implying high prevalence of subclinical LV systolic dysfunction. Furthermore, the patient presenting with one or more symptoms had much lower GLS as compared to those who are asymptomatic. And these findings underscored the utility of GLS in the evaluation of the post-COVID population and suggest GLS should be measured in every symptomatic post-COVID patient to detect underlying myocardial dysfunction. And this is the study. This is the name of the clinical profile and the extent of the myocardial dysfunction among patients with the previous coronavirus disease 2019 episode. And this article has been already sent to the International Journal of Cardiovascular Sciences. Myself with Dr. Manish Bansal has then combined this study. Many patients who have recovered from their coronavirus disease, that is the background, we have studied 472 subjects of this median age with previous COVID. Median duration 18.9 plus minus 13.9 weeks with 100 controls, age matched. All subjects underwent detailed clinical assessment and echocardiography, including the GLS. We have almost taken the 13 parameters, clinical parameters: age, gender, presence of hypertension, diabetes mellitus, pre-existing obstructive airway disease, then body mass index. Then what we found among the clinical parameter, most important that the commonest presentation are asymptomatic. And then is the exertional dyspnea or the breathing difficulty. There are certain parameters, whether there is oxygen requirement is there or not, presence of remdesivir, any ventilation. So these are the all criteria we have taken. What is the summary of this? That exertional dyspnea and the breathing difficulty at rest were the commonest reasons, 3 out of every 5 cases for current clinical presentation. While the chest pain, palpitation, generalized weakness with other reasons. Nearly 1/6 of all subjects had presented by unrelated reasons. A majority of the subjects had a relatively mild infection. Less than third needed hospitalization. Almost the same proportion required oxygen support. Non-invasive or invasive ventilation in certain 5%, and a sizable portion received steroid, whereas remdesivir were hardly used. This is the comparison of the post-COVID patient with the controls, and you can find there is a definite statistical difference of the LV-GLS. There is a definite ejection fraction was not much of a difference, statistically different, but there not much of difference because of the variability in that determining the rejection fraction, because the GLS is the most robust and most reproducible. So as compared to the control, post-COVID subject had significantly lower LVF and the LV-GLS, whereas mitral, very important, is that E by E prime was significantly higher. And this was despite the absence of significant difference between the two groups in age, gender, BMI, and the prevalence of hypertension and diabetes. The estimated PA pulmonary systolic pulse also was not different between the two groups. Most patients have previous COVID-19 had normal LVF. However, GLS was abnormal in 18.4, almost 20% of patients using mean -2 standard deviation GLS volume control as the reference. For the time, I'll skip some slides. Is that another important factor is, and important findings is that compared to the patient presenting beyond 12 weeks, those who had presented early after their COVID-19 episode were more often symptomatic and were more likely to have received steroid previously. However, there is no difference in the comorbidities and the need for hospitalization for oxygen use. The patient presenting early had a higher PSP as compared to those that presented late. But the LV systolic and the diastolic function parameter did not differ between the two groups. However, GLS was much lower in symptomatic patients as compared to the patients who were asymptomatic at the time of current presentation. This is a difference of asymptomatic or presentation in this there. That I already, pulmonary systolic patient difference is not much. These are the another need for hospitalization in the COVID-19 episodes. That I'm skip this slide. Use steroid use remdesivir. And the post-COVID subject categorized in tertiles of left ventricular global longitudinal strain in 3 groups. When grouped into LVGS tertile, the subject with the worst GLS was older, more likely to be men, and higher BMI, and a higher prevalence of hypertension and diabetes. They also had more severe initial infection with greater need for hospitalization, oxygen therapy, and steroid. The patient with the lowest GLS had lower LVF, but mitral E by E prime ratio and PSP were not different. That is very, very important. That's why the patients are asymptomatic. I'll see the representative side of the tertile, GLS tertile in normal control, and this is the GLS tertile of -19.1 or more, that is the almost normal. And in between there is the intermediate group, there is -16.3 to -19.1 is the intermediate GLS tertile, and less than, we took up the cut of -16.3 and the lowest GLS tertile. We also observed that the impairment of GLS correlated well with the severity of the initial illness. The patient with the worst GLS has more severe initial infection with greater need for hospitalization, oxygen therapy, and the steroids. They also had a higher burden of comorbidities. They support the robustness of this GLS as a measure of myocardial injury. The prevalence of impaired GLS in our study was much higher than that was reported by study by Mahajan et al. This may be because we did not limit our recruitment to patients with documented normal LVF. Moreover, we also did not exclude patients with the diabetes mellitus and hypertension. Our findings are thus more representative of the population that seeks medical advice following their initial COVID-19 infection. It is also noteworthy that unlikely that study by Mahajan et al., we used mean -2 standard deviation of GLS in the controls as the threshold to define the impaired GLS. And this would be a more appropriate cutoff than any value below the mean GLS. We found it that 18.4%, that is near about 20% of the all post-COVID subjects in our study had abnormal GLS during this definition. Of course, our study has some flaws and limitations that merit attention. In our patient, we did not have a direct information about the extent of myocardial injury during the initial episode of COVID-19. Therefore, sorry for 2 minutes, had to rely on their other markers of disease severity, such as the need for hospitalization, oxygen use, and the ventilatory requirement. However, echocardiography was the only diagnostic modality used in this study, and the findings were not corroborated with any other imaging tools such as CMR. We did not have any baseline echocardiography data for our patient, hence it was not possible to determine if the echocardiographic abnormalities found during the present evaluation were pre-existing or new. To overcome this, we included controls who were matched for age, gender, and two common cardiovascular risk factors, namely the diabetes and hypertension, which are also the common reason for subclinical LV systolic dysfunction. We believe inclusion of such subjects as control allowed us to better access the true prevalence of LV myocardial dysfunction in post-COVID patients than the previous studies. So we concluded this study. This study shows that impairment of LV systolic and the diastolic function is common among subjects recovering from previous COVID episode, and the patient with more severe initial infection have marked impairment of LV function, and these impairment persist even after several months of recovery, at least if followed up to 1 year from the initial infection. LV-GLS should be done in all cases of post-COVID evaluation, even if the ECG and the LV abnormal in routine evaluation. We are still facing pandemic unseen in our lifetime with potential long-term cardiovascular complication. But this is my appeal. Now is the time for action to plan appropriate registries and the clinical studies to assess the incidence and significance of the potential mid and the long-term cardiac abnormalities and dysrhythmias with the hope to promise to mitigate this long-term sequelae. Thank you. There are certain lack of time. I could not show. There are 4 representative cases, how we evaluated, that I could not show you because in case the cases are there, but because of lack of time, I could not show you because already I finished my time.
Thank you so much, sir, for this absolutely flawless presentation and this flawless study. Sir, just a quick question. You had 2 very brief questions. Sir, what was the mean time or more or less the average time when you found the GLS to become normal in those children, in those patients
very important,
who had got...
Very important question. Actually, we followed this study for the 1 year. What happens initially we studied for 12 weeks. We are taking this patient for the first, just after the initial COVID infection, after 2 weeks to 12 weeks, we studied that. And then we followed this patient to the after 1 year. And believe me, almost 60 to 70% patient, the GLS become normal within a year.
Sir, did you do any study of the GLS in between 12 months to 1 year?
3 weeks to 1 year.
Yeah.
Yeah, in between 3, that means 3 weeks, 3 months to 1 year, in between that. And actually the patients are coming in between that. We cannot force because all the patients are not mine. But I am doing the echocardiography. All the patients are not mine. Then that is the difference.
In the pediatric age group, the studies are saying they normalize by about 1 to 3 months.
That would have been better. That would have been better. Such and such time it has become abnormal. But I am telling you that not all the patients, even some patients after 6, 7 months, the GLS may be that is in the lowest tertiles become into intermediate tertile and ultimately go into the lower tertile. But to become the 60 to 70%, that is another study still going on, the 60 to 70% patient within 1 year become almost to the lowest tertile to the normal tertile. Because we are not giving importance to the lowest tertile patient because below 18, that means below 16 to 18% patient, we are not, because there is a lot of patient having hypertension, diabetes, comorbidity, it itself reduces the GLS.
Yes, sir.
Just a few observations. Number one, they were symptomatic, complaining of breathlessness on exercise.
Yeah, majority are symptomatic.
Did you at any point do any stress diastology on any of these subjects?
No, sir. You can see the almost 50% patients are asymptomatic. They are referred to ask
For
to
symptomatic patient, you said
symptomatic
some of the
patient.
patients were
Yeah, yeah.
symptomatic. So stress study, stress echo would have been useful for them. So even if you do in 10% of such patients, that would give you more information.
Yeah,
And
that's true.
since, as Devdatta said, that many of the times if you find it is reversible, that it is going back to normal, the GLS after 6 months, then probably it will be easier to say that it is due to COVID. But unless you demonstrate reversibility, unless you exclude underlying coronary artery disease, how would you know that in this 50+ population with underlying
agreed.
hypertension, diabetes in many
Agreed.
of them?
That is
So
the
that
drawback
is
of the
another
study.
limitation.
That is the drawback of the study. And I'm telling you, sir, but that's why we've taken the, as a population, the age-matched diabetic control. So, yeah. And that's why taken the cutoff to 16. Not, and another important fact I'm telling you, another important fact I'm telling you, that is that we now have a study in a population where there is only diabetes or only hypertension or only diabetes with hypertension without any coronary artery disease, maybe with mild coronary artery disease, their tartile range not going below 16%. So particularly these patients, that 16 to 18% patient, 18% tartile group maybe fall into this category where there is already impaired LV function. But below 16%, that's why we've taken the cutoff of 16%. Below 16%, we have taken 20%. That 20% I'm telling you, the below 16%.
Sir,
That's
just one last brief thing. Sir, did you find, even in those with normal GLS, did you find any change in the exact numbers? Suppose someone you found to be 20, maybe a little more.
That's why I'm telling
you. Did
you.
you find any jump in the numbers, even in those with normal strain patterns?
Normal. We got certain percentages of course, the majority percentages within either in the range of 16 to 18% or 18 beyond. 18 beyond we took as a normal. EF is normal, ECG is normal, beyond 80% GLS, we took it as a normal. It may be 25% in a young patient.
Sir, that is what I'm
but
asking.
in
Did you
between,
find any jump in the numbers in your cases?
Yeah. But we took only the patient with the less than 16%. Keeping the diabetes, hypertension and the comorbidities in it. And if you see, our control group had 18%. Even with the diabetes and hypertension and combined diabetes with hypertension. That is the age-matched control.
Thank you so much. Thank you so much for this wonderful session.
Thank you, sir.
Congratulations,
Thank you.
sir.